It's been a long and information-packed and wonderful day, and I know that we're all getting a bit tired. But I do want to talk about reforms, and I am going to really just hit the high points. We've encountered barriers that astonish me, of institutions unwilling to take care of patients. I don't understand that. We've encountered physicians who seem not to care about patients getting cared for. I don't understand that. And we encounter reluctance because of novelty. I thought our tertiary care institutions were to create novelty. And what we see is an unwillingness to consider novelty in many places. And so I won't spend a lot of time talking about those things because I don't have good ideas about how to solve them. They're human being problems. There are limitations in imagination and limitations in the way organizations actually work. And most of the time, we can't even figure out who makes the decision in a tertiary care institution to join us or not. We don't even know who makes those decisions. So there's a lot that we need to learn and do that have been tremendous surprises to me personally and deep disappointments in many ways. But there are some obvious things that I think cry out for us to put our shoulders to the wheel to change. And I want to preface all of this with reform is not easy. If you think about driving reform, you need to get ready to persevere. And there will be many, many solid reasons that people will raise against doing something that hasn't been done before. And then there will be a host of nonsensical reasons that are raised for all kinds of reasons. And so I do not make these recommendations lightly in any way. And I do not minimize how much effort is going to be taken to get this done. But I do say that if we don't tackle these things at the N of 1 level, they may never happen. And we cannot wait. We cannot wait to get to work on these. And so I believe strongly that the single most important step forward to enable a more rapid diagnosis of nano-rare patients and all patients is that we introduce genomic sequencing and whole genome sequencing into newborn evaluation protocols. Now, there are tremendous benefits from that. It will not even begin to solve all the problems, but it will begin to identify the problems for us in an earlier and more convenient and more actionable way. If you think about it, we have no idea what the incidence, real incidence of non-pathogenic and pathogenic mutations is. We don't know what the prevalence of any of these things are, and we will not know until programs like Genomics UK actually spread around the world, and we sequence every human being. And that's just, of course, the beginning. We don't know today which mutations are pathogenic and which are not. We don't have a reason to understand. We don't have even an intellectual basis to think about all this in a functional way. And until we gather some of this information, we will never get to nano-rare patients before they're already progressed well beyond the place where they need to be. So it is critical. I think it's also fascinating to think about early identification of potential environmental factors or genetic factors that are driving mutational changes in populations. And I do think that happens. And again, how will we learn that if we don't begin sequencing populations of human beings and correlating that with phenotype in a patient-identifiable way? There are a lot of genotype databases, GWAS, a lot of phenotypes of various kinds. I think that's been invested enough, frankly. I think now we need to bring genotype, phenotype, and patient together in fashions that are then actionable and understandable. What are the single gene mutations that cause disease? What do those diseases look like? I would love to see a compendium of the nano-rare mutations and the syndromes associated with those. We will never have that if we don't begin to think about just this very first step. And of course, we can reduce cost. Long term, there's no question, and I think the UDN has done a beautiful job of demonstrating that just achieving a diagnosis is a fundamental advance in terms of emotions and care, but it's also a fundamental way of reducing cost of healthcare. And so anything that will allow us to move more rapidly to a diagnosis is going to reduce healthcare costs, going to reduce journeys that are non-productive and often destructive, and going to reduce the harm that happens to our patients before they make their way to us. We need to do that. And then there will be lots of issues. What about the risk of misuse of the information? There's a lot of people who worry about labeling, their children. I think, frankly, that's getting the cart before the horse. I think if you don't have a diagnosis, you don't have a label, but you do have a problem. And so I think these are legitimate issues that we have to work through. We certainly don't want a rebirth of eugenics and all of the abuses that can take place there. But these are manageable problems. We can't spin around and worry about those things. Those are soluble problems. It is not soluble to help a patient who's progressed to the place that they're beyond help. That's an insoluble problem. And so I think good people can come together and find solutions. I think that's not enough. What I'm looking forward to is coupling genomics and phenotype and standardizing phenotypic descriptions. We have multiple examples of just terrible phenotype descriptions from the physicians that we're seeing. And these are the top-of-the-line physicians. They're taking care of patients in academic centers. And there's just tremendous variability in what gets characterized as a phenotype and what doesn't. Right now, we're digging in through our data just to see how many ion channel patients actually have GI symptomatology that wasn't bothered reporting, that nobody bothered to put down on a case report. We know it exists. So we need to find ways to enhance genotype to phenotype, and we need to enhance the ways of describing phenotype and do a better job of standardizing that and assuring that every possible element of the phenotype is recorded. Just because you're not a gastroenterologist doesn't mean that the gastroenterology problems that patient has shouldn't be recorded so that we know about it. And we see a lot of that. We see a lot of it. So the benefits, of course, I think are obvious. Again, as we think about coupling genotype to phenotype, patient confidentiality and potential abuse of that information becomes central. And I would, again, just say, yes, that's all true. But yes, that's a soluble problem for good people to put their heads together and find solutions that will work. It is an insoluble problem if we don't have the information. So that's number two. Number three, I think of epidemiology studies. I'm a hypothesis testing scientist. I see we're in big data and GWAS and yada, yada, yada. But in the end, that's all screening information that then generates the opportunity to test hypotheses. And I think of traditional epidemiologic studies as body counting. Framingham was wonderful, but it's time to move on. And here, if we can couple genotype, phenotype, and then long-term follow-up to omics, and there are multiple omics. And the genotype is in some ways the most state of information, and what we need is kinetic information that we can get from transcriptomics, from proteomics, from metabolomics, from methylomics, and so on. And so there are some technological advances that are needed, there are cost improvements that are needed, but if we could, for example, take nano-rare patients who have a defined, well-understood pathogenic mutation and couple that to long-term follow-up and multiple omic evaluations, we could begin to conduct molecular epidemiologic studies. That would begin to teach us at the cellular and molecular and pathway level about health and disease. It's time to move beyond counting bodies, in my view. The benefits are just knowledge, just how much knowledge we're missing that could be available to us with just the methods that we have today, with just some changing in funding. And if we could encourage people to see the incredible value of a human being with a single variable as a test model for health and disease, I think we could really do some good. And again, these are the same problems, the patient confidentiality and costs and so on and so on. But I would say take $1 billion that we spend on animal models and try putting $1 billion into human models. Call them nano-rare human models. We spend how many $1 billion a year doing that, animal models that nobody likes. We have these patients who are the model of the future of health and disease. So another thing that I'd like to see happen. This is another one. We find there's an incredible amount of money for research that's long-term defined treatments. But what we were shocked at was when we said, okay, well, that's great, but we can help a patient today. We had a very difficult time getting people to get beyond the fact that no, their system is designed to support research to find a treatment. And it just seems to me that we need to think about reallocating resources. Not a lot, we don't need a lot, but if we just reallocate some of the money that's invested in more traditional approaches to thinking about these patients as an extraordinary resource, and that the treatment of these patients with specific genetic therapy provides an extraordinary opportunity to learn in reverse about the ontogeny of disease, I think we could do just a lot more. And so it is about money. But it's about thinking in new ways that are now available to us because these patients are now known to exist. We didn't know they existed until we did sequencing. Now we do. How do we take advantage of them in the most efficient way? So it would be good if we could work together to change NIH funding so that there was more money for nano-rare patient research and opportunities to help institutions with the financial costs of treating these patients in a more research-intensive environment. And that just requires a small shift in the billions of dollars of NIH money. It doesn't require a lot. It won't. And yet, it will make an enormous difference. Again, one of the big things I wanted to get out of today for all of you so that you can carry this forward is the unbelievable research opportunity these patients represent. And we need to encourage then more and more scientists in academia to be interested in these as models of health and disease. We find an astonishing lack of interest in academic centers in this remarkable resource that we're bringing to them, a patient with a single variable introduced, driving an enormous phenotype. Let's see, what else do I want to say? I'm really, you know, I grew up in cancer, and the first 5 years of my career, I built the first broadly successful anti-cancer program in the industry. If you can believe it, there was the conventional wisdom, and when I went in the industry, is you couldn't make money in cancer. Well, I've changed that. And one of the things that cancer treatment taught us very early is that you need to think holistically about the patient. You need a team approach. And what we see in these patients is deeply disheartening in that they're cared for by an individual physician. The places that are doing great jobs, like Columbia and so on, they really bring a team together, and they recognize that these mutations affect an individual, but they affect a family, and that we have to think about these patients holistically, and we have to think about the family, and we have to bring teams together to think about the entire phenotype of that patient, that we bridge somehow the gap between a neurologist and a gastroenterologist and a hematologist and so on. That's been done. It should be done for these patients. And one of my real concerns is that sort of system weariness that I mentioned earlier in the day, where it seems like there's a tremendous amount of energy invested in the patient initially, and then when there's no answer, no solution, it seems like the system loses interest. That patient is still suffering. The family is still suffering. Where's the support? Where did that go? Why is there no one taking care of Connor Dalby for 10 years? Why is that? How can that be? How can we allow that to happen in our medical system? It's got to change. So that's a very high-level list. I'm sure that there are many other opportunities for reform, and I'm sure there are lots of concerns about this and that and the other. But I believe strongly that treatment is always the tip of the spear that drives reform. And n-Lorem can be the tip of the spear. And so I ask that all of you think about these, and those reforms that you think make sense, I want you to join us to help begin drive those reforms forward. I don't ask that you agree with everything I just said, of course not. But where you do agree, then join us in helping drive those reforms in the coming years. It's a big deal, and it's a big opportunity. And to see so many of these patients suffer and die, and the opportunity to help missed, and the opportunity to learn squandered, is heartbreaking. I want to see it end. Make sense to everybody? Ask for your help. Thanks.